There's already, I'll throw them in at the deep end, a surgeon, colleague at Imperial College, he's a consultant gynecological oncologist at Imperial, but also very involved, well, runs or is involved in the diagnostic side, and very, very, like Ahmed Sayasna, the new breed of gynae-oncologists who both operate and can do the imaging themselves, etc. So I think this is, if you like, you know, the future of these meetings. So they're going to have an MDT with Francesca, and they've got some cases. Ahmed's going to chair, and with certain, I should add, surgeon is also chair of the NGen group. So anyone who's young and enthusiastic about ultrasound should be contacting surgeon within ISWOG, because he chairs the NGen group at ISWOG as well. So I'm going to hand over to them. They're going to discuss some cases. Do write in on the discussions section on the right-hand side if you have any questions, please, any comments on the cases, and they will all deal with that. I'm going to hand over to Ahmed and see you for the session at 2 o'clock GMT. So thanks all of you for taking part.
Thank you so much, Prof. Thank you. Great sessions. Okay, I think the next session is interesting. It's about some interesting ovarian masses and how to manage them. It's going to be in an MDT setup. So there will be lots of discussion. MDT, multidisciplinary team discussion involved normally surgeons, medical oncologists, clinical oncologists, histopathologists, other surgeons, other specialties, radiologists. So we're going to kind of mimic some of the features of the MDT. So Francesca, thank you so much for the talk earlier, and thank you as well for presenting the slides and take us through this. Surgeon as well will be telling us from his experience about the different ways of management and opinions. So please go ahead, Francesca.
Okay, so let's start. So this is the first clinical case. We have a 51-year-old patient. The BMI was 31, nothing relevant in her personal history, and she had abnormal uterine bleeding. So this was our ultrasound examination. We can see the uterus, and we can recognize a lesion in endometrial cavity. And according to the AITA terms, we describe it as endometrial lesion with inhomogeneous echo structure. And what about endometrial malmetrial junction? I think junction is interrupted. So this is the color Doppler examination, and we define the endometrial lesion as richly vascularized with multiple vessel pattern. With transvaginal ultrasound examination, we can assess the myometrial invasion. We can use subjective assessment, or we can also use objective measurements, including minimal tumor-free margin using 7 millimeters as a cutoff, or the ratio between a tumor and the uterine anterior-posterior diameter. This is our image. This is the endometrial lesion. The myometrial margin was 3 millimeters, so less than 7 millimeters, and the ratio was less than cutoff, more than 0.53. So we described the endometrial lesion with an myometrial infiltration more than 50%. Then I rotate the probe 90 degrees and I move the probe on the right side to assess the right adnexum. In the right side, I found this lesion. So we describe it according to the IOTA terms as solid lesion of 36 by 35 by 44 millimeters with regular margins and no shadowing. This is the vascularization. So the right solid mass was richly vascularized. We also found another solid lesion on the left adenexum. So I thought that there was a normal ovarian parenchyma and a solid lesion. And this was the vascularization, sorry. So endometrial lesion with myometrial infiltration more than 50% and bilateral solid tumors.
Excellent.
So, summarizing the clinical ultrasound characteristics of this lady, we have a 51-year-old patient examined at our oncological center, solid tumor. This is the large tumor diameter, no shadowing, no ascites. It was richly vascularized. So the CA125 was elevated. My hypothesis, first one, endometrial cancer with ovarian metastasis, but the other option is synchronous tumors.
Can I just ask you at this stage, did you ask for any further imaging, Francesca, or that's it?
Yeah.
Okay. Did you look at the lymph nodes at this stage with the ultrasound? Do you normally look at the pelvic lymph node to see?
Yeah, we normally look at the pelvic, but I didn't find any lymph nodes.
Okay. And what other imaging you asked on top of everything?
MRI or CT scan.
Okay. Do we need an MRI with the finding like this normally? What do you think, surgeon? Just because I'm trying to see different opinions, for the low resources, just in case we don't have an MRI. I mean, is that not enough so far?
I think, again, depends on the expertise, but the three of us, ultrasound should be enough. Of course, we will still talk to our radiology colleagues. In low resource settings, as we all know, getting an MRI is challenging. I think with putting the whole picture together, I don't know what you feel, but I personally am happy to go with this information.
I mean, I'm personally will ask just maybe for a CT chest, just on top of everything. I complete by abdominal ultrasound, CT chest. I think that would be reasonable and no resources. But I don't know what you both think.
Yeah, I completely agree.
Yeah.
Okay. Sorry, Francesca.
But it's the expertise of the ultrasound that matters.
Yeah.
We'll talk about that later on.
Yeah. Yeah.
Okay. So this was my subjective assessment, and then we used the two-step strategy. So we applied it to the right adnexal tumor because was the largest one. And we cannot apply the modified benign simple descriptors because it was a solid lesion. And after plotting all these variables in the iota adnex, so we calculated the risk of malignancy that was high, 89.1%. What about the relative risk of the adnexal mass? The highest relative risk was advanced stage primary invasive, but I noted that also for metastatic tumor was high. So according to the consensus statement, this is the adnexal lesion is high risk of malignancy. So the patient should be referred to a specialized gynecologic oncology center. So our department is a referral oncology center. After the tumor board, so we asked a CT scan that confirm the homogeneous of the uterus, the ovaries increased in size, and no lymphadenopathy, no carcinomatosis. The C125 was elevated because we supposed an endometrial malignancy, so hysteroscopy. She underwent a hysteroscopy, and the biopsy was, the histology was endometrioid endometrial carcinoma grade 2. The patient underwent surgery and total hysterectomy, bilateral salpingo-oophorectomy, sentinel lymph node biopsies, and peritoneal biopsies were performed. And this is the Froven section, moderately differentiated adenocarcinoma. So just before concluding, I would like to show you the macroscopy, comparing with the ultrasound image. This is the macroscopy of the right tumor, and this is the left tumor. So what about final histology? This is the final histology report of the ovary, endometrioid ovarian carcinoma, FIGO grade 2. This is the endometrial histology, was same grade. So endometrioid endometrial carcinoma, FIGO grade 2, with minimal invasion of the cervical stroma. This is the immunohistochemistry, and so MMRI proficiency. So mismatch repair proficient. So this is the report from our pathology. The bilaterality of the adnexal lesions and the grading concordance between endometrial and ovarian cancers suggests diagnosis of ovarian metastasis. So, according to the FIGO stage, so this is an endometrial cancer with ovarian metastasis, so 3A, stage 3A. This is the risk group classification. It was mismatch repair proficient. It was not deficient, but because it was a stage 3 with ovarian metastasis, this is a high risk endometrial cancer, and the patient underwent radiotherapy with adjuvant chemotherapy. Do you like to make any comment, Ahmad, or?
I think that's brilliant so far.
Thank you. I think the big thing to talk about here, Ahmed, I mean, you're sharing, but is the synchronicity.
In truth, and whether this is a primary, two primaries, or one primary, secondary.
Exactly.
I think the way Francesca explained it, yeah, that's very good.
What should one do?
Yeah, sorry, surgeon, go ahead.
No, just what should one do?
I think we depend a lot on the histopathologist in this case, correct? I mean, the histopathologists normally are the ones to tell me what they think, and I go by them. I think the only fact that this is a bilateral makes me less convinced that this is synchronous. But the fact is, that's the only clinical finding from ultrasound. But normally the histopathologists are the ones to tell us what they think about this, because it's interesting, because that changed the whole management.
Yeah. Yeah, no, I mean, and also the kind of the key message is always go for when you have a situation like this, to an ovarian endometrial or a metastasis of an ovarian or a metastasis of an endometrial, go for the worst case scenario.
Definitely.
Out of the 3 potential scenarios, go for the worst case scenario and treat it according to that.
Definitely. Now, there is a question from the audience, which is interesting. I want to share with you, which is actually in the resource constricted environment. Can we depend on the CT instead of CT chest? Can we do an X-ray or chest X-ray? To know, what do you think?
I think yes. Again, it depends.
I think you're already constricted, aren't you? So I think, yeah.
What option do you have?
What else can you do? True.
Exactly. CT chest is a luxury. There are also small, but they're worth mentioning, drawbacks to having a CT chest, especially in a young woman. We do know that for the young germ cell variant tumors, but that's the next case, the follow-up can be with chest X-rays. So in a constricted environment, yes, do it. Especially in the low-grade early stage tumors. If you look at the percentage of those that have positive CT chests, the numbers are small, and we almost automatically we do them automatically here now in at London. I'm sure Tom is as well.
Yeah.
But maybe that's an idea for a project. How many of those CT chests in low-grade early stage endometrial / ovarian cancers are positive?
Indeed. And the other question, do you foresee ultrasound scan replacing CT and MRI in the working of cervical cancer? I think we talked about this. I think, yes, ultrasound scan definitely is very, very efficient in the cervical cancer staging. Now, in terms of the lymph nodes, that's another talk. I think CT will be enough, and I think MRI can be replaced safely by ultrasound scan in the hands of experience. The problem with that, I think training is the issue here. And I think if you have someone who's really trained and knows what looking at, and that will go through different cycles. I mean, for me, I always do the scan for my training. The way I do it, I'll do the scan even intraoperatively. And I'm lucky to have the MRI, but I still do the scan because afterwards I just correspond that with the surgical finding and with the histology finding. And if you do this cycle all the time, and if you've seen with Francesca's slides how she cut the tumor to show you that the area of the endometrial cancer matching the ultrasound scan area, I think by doing this, you're matching your final outcome with the index test. Anyway, shall we move on?
Yes.
Sorry, there's so many questions and we don't have to have time. Francesca, next case.
So this is the next case. So young lady with abdominal pain. This is our ultrasound examination. So this is a large solid tumor with the cystic areas. We define it as a solid and not a multilocular solid because the solid component was more than 80% of all lesion. And this is the vascularization. So, right solid mass, nearly 90 centimeters, with irregular margins, inhomogeneous structure, solid with the cystic areas, and richly vascularized. So, any idea? We have a young lady with irregular solid tumor. Some shadowing was